Okay, hello everyone, welcome. We are actually going to get started today kind of right at the dot of 1 o'clock or 1 o'clock Central Time, because we have, Dr. Cortezzo has a lot of content to go through. So to just jump us in, welcome to the webinar series Together in Care. Today's topic is neonatal symptom management for complex NICU patients and in end-of-life care. Our speaker is Dr. DonnaMaria Cortezzo, and I am your moderator, Rose Doolittle. I'm a neonatologist at Oklahoma Children's. A little on Dr. Cortezzo. So Dr. Cortezzo is a neonatologist, hospice and palliative medicine physician, and the neonatal lead for fetal care at Connecticut Children's. She has an appointment as an assistant professor of pediatrics at the University of Connecticut School of Medicine. She works primarily in the Level 4 NICU and Fetal Care Center, with her clinical interests spanning fetuses and neonates with multiple congenital anomalies, complex diagnoses, congenital diaphragmatic hernias, complex airways, neonates requiring surgical intervention, ECMO, neonatal pain management, and neonatal perinatal palliative care. She counsels families with various complex prenatal diagnoses and partners with them to create personalized birth plans and care strategies. Her research focuses on improving outcomes for neonates with complex diagnoses, neonatal perinatal palliative care, neonatal pain management, bereaved parent experiences, and communication and counseling and shared decision-making. If she looks familiar, it's because she also did our general introduction to neonatal perinatal palliative care, and we are thrilled to have her back again today for this talk. Next slide, please. A little housekeeping. So our next webinar the topic is bereavement, with speakers Dr. Conrad Williams and Nicole MacDiaz. It will be on October 6th at 2 p.m. Eastern Time, and there are many QR codes here. The middle one is to register, and the other QR codes are for our website. Okay, I'll turn it over to Dr. Cortezzo.
Thank you, Rose, for that wonderful introduction and for inviting me to return to this webinar series. As mentioned, today I'll be talking about neonatal symptom management, both for complex NICU patients and for end-of-life care in the NICU. I have nothing to disclose. Pain and symptom management is important for any patient, especially in the intensive care unit and at end of life. In this session, I really hope to review symptoms commonly seen either with complex patients or at end of life in the NICU and discuss management options. Then I'll walk through 2 cases to illustrate how to apply some of these management strategies. This really is a broad and nuanced topic, but hopefully I can provide a general overview and some strategies. With continued advances in technology and therapeutic interventions, more premature, critically ill, and medically complex neonates are admitted to the NICU. Their hospitalizations are longer and accompanied by more invasive procedures and therapeutic interventions that may result in a variety of symptoms. With an increased understanding of the impact of pain and other symptoms, their assessment and effective management really has been endorsed by multiple medical societies. This though requires an understanding of the pathophysiology and evaluation of each symptom. It also requires an understanding of the therapies available and the side effect of those therapies. Specific to end-of-life care, the majority of neonatal deaths still occur in the NICU. These are typically the result of a redirection of care after a trial of therapy lasting anywhere from days to months. While the hospital course and care is complex, it gives us a unique opportunity to really anticipate symptoms and needs of the patient, prepare the family, and develop management plans. In general, it's important to do a thorough assessment of the patient, etiology of the symptoms, and family concerns. This may include past experiences, as it alters how they perceive what's happening and what might be distressing to them. It's important to set realistic expectations, have open, honest conversations about their hopes and whether we can achieve them. If they're hoping that their baby who recently had an XLAP has no pain, help them reframe their thinking to minimize his pain. To optimize management, we often combine non-pharmacologic and pharmacologic therapies. Medications need to be titrated frequently with continuing assessment of the patient's response, which means we need to be present to ensure we're adequately addressing the symptoms and that we're supporting the family. With end-of-life care, preparing the family for what to expect during the dying process really helps to alleviate anxiety. By understanding the physical changes, some families are less distressed by symptoms such as gasping and color changes. They feel more prepared for the death, have less grief, and are more satisfied with the care their child received. Through open communication, we can address misconceptions and encourage families really to convey when they're concerned that their baby is uncomfortable. We can also empower them by involving them in the plans and showing them how to make their child more comfortable. To manage any symptom, a thorough assessment is critical. Assessments ideally should span that biopsychosocial spiritual model. Our patients, though, can't tell us what they're thinking or feeling, making this more challenging. The family might have fears of what symptoms mean, that their child is not getting better. There can also be language and cultural differences to navigate. Some cultures have beliefs, for example, that pain and suffering are really a necessary part of transitioning to the afterlife. There are also challenges with making an accurate assessment. Few standardized tools exist to assess the various symptoms in neonates. Families may have different assessments of symptoms, as clinicians tend to rate symptoms lower than families do. Additionally, few providers have advanced or end-of-life symptom management training. They may not have comfort managing more complex cases. And even with knowledge and training, it's challenging because it takes time to fully understand and effectively treat symptoms, and symptoms often change over time. The physiologic response and pharmacokinetics in neonates may be different than in other populations, further complicating these things, but preparing whenever possible can help. Given the unique challenges with neonates, it's important to remember that you don't have to do this alone. Caring for them is really a team effort, and effective symptom management often requires a truly collaborative approach. Pain and palliative specialists have advanced symptom knowledge that can complement the multidisciplinary neonatal team's expertise of the population and pathophysiology of the baby's condition. Parents bring their expert knowledge of the baby drive for many hours, days, and weeks at the bedside. They're often sensitive to subtle early signs that providers can miss. Our complex, critically ill, chronic NICU patients may experience many symptoms. The most common ones are pain, agitation, stress, and neuroirritability. Delirium is a relatively new concept in our patient population that may have an impact on short and long-term outcomes. There's some but not complete overlap in end-of-life symptoms. In a study of bereaved parents, mothers most often noted respiratory distress, agitation, and pain, while fathers most often noted respiratory distress, agitation, and lethargy. Both parents reported respiratory distress as the worst symptom in severity and the most difficult to watch. On average, parents reported that their babies experienced a moderate amount of suffering around the time of death and felt that their child's symptoms could have been managed better. Symptoms commonly seen include dyspnea, pain, agitation, neuroirritability, and secretions. Since neonates can't tell us what they're experiencing and may display symptoms differently than others, symptom evaluation is largely reliant on clinician and family perception. Consider the clinical circumstances. What's the underlying disease process? This will help determine which symptoms we should be worried about, their baseline needs, and really how to adapt treatment. Has something changed clinically that caused us to worry about a new or changing symptom? Is this an acute change or something more chronic? Do we expect the symptoms to be short-term or long-term? If this is in the context of end-of-life care, what are the circumstances surrounding the death? How long do you anticipate the patient will live? This may change our symptom management approach. If the neonate recently had surgery, they may have significant pain and need an escalation of medications. In other cases, the symptom may be respiratory distress or secretion management. If a baby's had a brain injury or a prolonged hospitalization, agitation and neuroirritability may come into play. This is not a one-size-fits-all approach. It really needs to be tailored to each patient. Next, I'll talk about each symptom and ways to address them. One of the most common and challenging symptoms to treat in neonates, both within and beyond the context of end-of-life care, is pain. Pain is an unpleasant sensation that results in discomfort and distress. The etiology and degree of pain experienced by complex NICU patients or during the dying process can vary greatly. Characterizing it is important because identifying the type of pain and understanding the etiology and mechanism can help direct treatment. Is it acute or chronic? What type is it? Nociceptive pain is the result of tissue damage or inflammation and can be somatic, localized to a specific region, or visceral, affecting the internal organs. Neuropathic pain is a result of damage or irritation to the nerves. Each is managed differently. Validated tools such as NPAS really objectively assess pain. It's important to remember, though, that each tool has been validated for certain circumstances. For example, NPAS is validated for assessing both acute and chronic pain and agitation, including in postoperative and intubated patients. So it's really important to know the limitations of the tools that you're using and what they're validated for. These tools, in conjunction with caregivers' perception, are used to determine if a baby's in pain and to help guide management. Once we understand the nature of the pain, we can develop a treatment plan. Pain is a symptom, and in addition to treating the symptom, it's really important to consider whether we can treat the etiology of the pain. Certain disease-modifying therapies may make a patient more comfortable. This can include diuresis for severe edema, treating a cellulitis, ileus, or pneumothorax. In other words, can we treat or ameliorate the cause of the pain? Beyond that, we often use non-pharmacologic and pharmacologic interventions to treat the pain itself. Each of the non-pharmacologic methods on the slide increase comfort or decrease oxidative stress markers in neonates with pain. They should be utilized whenever possible. Care should be taken to reduce uncomfortable procedures, invasive touch-in, and frequent assessments. If this happens to be in the context of end-of-life care, are things like routine blood work or frequent vitals still necessary? When pain persists, interventions such as decreasing stimulation, massage, swaddling, skin-to-skin, and non-nutritive sucking can be beneficial. They also empower parents and promote positive bonding experiences. While non-pharmacologic interventions are helpful, they're often not enough. When selecting a medication, it's really important to consider the type of pain, as I mentioned, the severity and nature of the pain, and the access the patient has to really tailor your treatment plan. These factors will help you determine the class of medication, starting dose, route of administration that will be most effective or make the most sense in the given situation. This schematic is a nice overview of where common pharmacologic therapies for analgesia and sedation act on the pain pathways. A detailed discussion about this is really beyond the scope of this talk. The intent, though, is really to show that medications have different mechanisms of action and the importance of understanding the etiology of the pain or symptom to really target therapies that will be most beneficial. For pain, we can break pharmacologic therapies down to non-opioids and opioids. Non-opioids are helpful for mild pain or in conjunction with opioids. In the first table, sucrose is effective at reducing pain behaviors during acute procedures. The exact mechanism of action is unknown, but some studies suggest it really acts on the central nervous system to increase endogenous opioids. If you're using it, it's important to remember a small amount should be placed on the anterior of the tongue where those taste receptors are, because if it's swallowed and it undergoes gastric absorption, it doesn't have that same effect. Next, acetaminophen is helpful as a single agent for mild pain or in conjunction with opioids for more severe pain. It can be given as scheduled intermittent doses, either enteral, rectal, or intravenous. And then on the second table, for more severe pain, several medications can be used in conjunction with opioids. Alpha-2 adrenergic agonists, clonidine and dexmedetomidine, the first two medications, have analgesic and sedative properties that can be helpful, especially when babies have been exposed to opioids for a prolonged period of time. Clonidine is usually scheduled and given enteral. Dexmedetomidine is most commonly administered as a continuous infusion, and it has a short half-life. The next medication, gabapentin, when used for pain, is most helpful for neuropathic pain or visceral hyperalgesia. In these situations, it can often be more effective than opioids. It requires absorption through the GI tract. And then finally, dissociative anesthetics such as ketamine have amnestic, analgesic, and sedative properties. It's typically reserved for more complicated cases where patients have significant opioid exposure and refractory symptoms. And typically it's given intravenous every few hours as needed, but can be given as a continuous infusion. Opioids act on the mu, kappa, and delta portions of the opioid receptor with varying degrees of affinity to each portion of that receptor. They're really considered first line for moderate to severe pain within and beyond the context of end of life. Historically, in end-of-life circumstances, providers were concerned opioids would hasten death. However, sedation supersedes respiratory suppression, and several studies have shown that opioids improve symptoms but do not hasten death. Also, it's important to remember that in this context, the ethical principle of double effect would suggest their use would be justifiable. All that to say, providers should not have concern when opioids are dosed and titrated appropriately. The specific opioid and route of administration will really depend on the clinical scenario. If the baby doesn't have IV access, most can be given enteral. Morphine, the first opioid, is used most often. It can be given multiple routes, has a longer half-life than some of the others, and in general is well tolerated. While intermittent dosing is effective, a continuous infusion can be considered with severe pain. The next opioid, fentanyl, is a nice option for patients without access since it can be given intranasal or submucosal. It can also be given transdermal, but that's rarely used in neonates due to challenges with dosing and variable absorption. With any route of administration, it's important to remember that it has a quick onset of action, so it's a nice option for procedural pain, but it is shorter acting than morphine, so it would need to be dosed more frequently. Hydromorphone is much more potent than the other opioids, so the equal analgesic dose is much lower. And then finally, methadone is long acting and may be a nice option for patients who have been on opioids for a prolonged period of time or who have chronic pain. It also treats neuropathic pain more effectively than the other opioids because it also is a non-competitive NMDA receptor antagonist. If your patient has liver or renal failure, it's important to remember that the medication selection and dosing will be impacted by that based on how they're metabolized. There are times when you may need to transition an opioid to either a different route of administration or convert to a different opioid altogether. It's important to know the equal analgesic dosing so that you don't over or underdose the medication. They're not one-to-one conversions. We're still learning pharmacokinetics in neonates, but I included on this slide commonly accepted equivalent doses. I personally think of everything in terms of equivalence to enteral morphine. So parenteral morphine is 3 times more potent than enteral morphine. If you're converting from enteral to intravenous, the dose will need to be decreased by 2/3. Parenteral hydromorphone is 20 times more potent than enteral morphine, so the dose will be significantly lower. Fentanyl is the most challenging to convert, and there's a wide range of reported conversion factors. But regardless of what you're converting to, the process is the same. First, I calculate the total daily dose of the current opioid, and then use the conversion factor to calculate the new daily dose. If a patient is receiving 5 milligrams of IV morphine every 4 hours, their total daily dose of morphine is 30 milligrams IV. To determine IV hydromorphone equivalents, multiply that by 1.5 to get 45, and then divide by 10 for a total daily dose of 4.5 milligrams of IV hydromorphone. It's also important to remember that there's incomplete cross tolerance between opioids, so you might be able to do a 20 to 50% dose reduction if you're rotating between different types of opioids. Once you determine the new total daily dose, then divide that into your per hour or per dose amount. This schematic demonstrates an approach for pain management. For moderate pain, the purple tablet, a reasonable first step would be 0.15 milligrams per kilo of enteral morphine or 0.05 mg per kilo IV. This may need to be adjusted based on prior exposure. In general, the dose can be increased 20 to 50% every 20 minutes as needed. If the patient has severe pain from the onset or despite escalation of intermittent morphine, a continuous intravenous infusion can be started, often with a loading dose. If the neonate's already on an infusion, the dose can be increased by anywhere from 20 to 100%, depending on the severity of the pain. You can continue to increase that dose as needed, as long as you're still seeing a clinical response and the patient is not having significant side effects. In those cases, that's when you can consider an opioid rotation. Sometimes even after titration of opioids, alternate medications need to be utilized. Medications such as ketamine, dexmedetomidine, or gabapentin really should be chosen based on the etiology of the pain. If the pain is neuropathic, gabapentin, 3 milligrams per kilo Q8 would be an optimal choice. Alternately, methadone, since it also is an NMDA receptor antagonist, can be considered. Otherwise, I would typically add dexmedetomidine at 0.5 mics per kilo per hour. I tend to reserve ketamine for situations where opioids and dexmedetomidine have really been optimized and the patient is still experiencing pain. In rare circumstances, when there's really a high symptom burden and inadequate symptom control, a propofol washout or palliative sedation may be appropriate. The next symptom, agitation and neuroirritability, are other symptoms often presented in our chronic patients at the end of life. Agitation and neuroirritability are unpleasant states of arousal. They can be the result of the underlying disease process, interventions, medications, or the environment. Autonomic instability, increased motor activity, restlessness, and disturbed or disrupted sleep are all common manifestations. Because the physical signs of agitation can be really similar to pain behaviors, even with assessment tools such as MPAS, it can be difficult to distinguish from pain in a nonverbal patient. It's really important to try, though, because the treatment is quite different. If you're treating pain with an escalation of opioids and the symptoms aren't getting better, maybe it's not pain that the patient is experiencing. Some of the same non-pharmacologic measures that are effective in managing pain, including skin-to-skin and swaddling, are also helpful with agitation and neuroirritability. Interventions such as making sure the environment is calm, massage, low stimulation environment, and familiar people are often very helpful. Even at end of life, babies know familiar voices, scents, and objects and appear to be comforted by them. For the pharmacologic interventions, benzodiazepines, the first two medications on the table, which activate the GABA receptors, historically have been first line for agitation. It's important to remember that they have no analgesic properties. Side effects include myoclonic jerks, hypotension, and at higher doses, respiratory depression, excessive sedation, or even a paradoxical reaction. Lorazepam is longer acting than midazolam and has an immediate onset of action. It can be given as scheduled intermittent doses, enteral or intravenous. Midazolam, while shorter acting, can be given enteral, intravenous, or mucosal, and it can also be given as a continuous infusion. The next two medications, clonidine and dexmedetomidine, are the alpha-2 agonists I mentioned for treating pain. They also treat agitation. Due to the long-term side effects of benzodiazepines, many, including myself, are now using them first line for agitation in the NICU. They can be very effective and do not impact the respiratory drive. And limited data suggests that in certain circumstances, especially dexmedetomidine, may actually be neuroprotective. The next medication, gabapentin, works on the voltage-dependent calcium channels and can be beneficial for neonates with neuroirritability, which is slightly different from agitation. And then the last medication, phenobarbital, primarily works as a sedative. I rarely use it and only as an adjunctive medication because it doesn't treat the agitation itself. It simply sedates the patient. This schematic demonstrates an approach for treating agitation. First, assess the etiology and maximize non-pharmacologic interventions. If agitation persists, consider starting clonidine or dexmedetomidine. Alternately, an as-needed dose of intravenous lorazepam or midazolam, 0.05 mg per kilo, can be started. At times, higher doses are needed to achieve adequate symptom management. In these situations, I usually start a continuous infusion of dexmedetomidine at 0.5 mics per kilo per hour and titrate that as needed. I only start midazolam infusion or even scheduled benzodiazepines after other options have really been maximized. Remember, with midazolam, there can be a paradoxical reaction. So if you're rapidly escalating the dose and the symptoms aren't improving or are getting worse, decrease that dose. And then alternately, adjunctive medications such as ketamine can be considered. If the primary concern is neuroirritability, as I mentioned before, starting gabapentin at 3 mics per kilo Q8 and titrating to effect might be more beneficial than a benzo. In rare circumstances, phenobarbital, a propofol washout, or palliative sedation may be appropriate. I mentioned a propofol washout a couple of times. It should really be reserved for truly refractory cases where an older term neonate is receiving high doses of opioids, benzodiazepines, and adjunctive medications, really with minimal response. Propofol directly activates the GABA receptor and is an NMDA receptor antagonist. When used to facilitate opioid and benzodiazepine weans, the rapid decrease of those medications enables the upregulation of the GABA opioid receptors, increasing their sensitivity. In theory, this should allow for improved efficacy of those medications after the propofol is discontinued. It really should only be performed by experienced providers after multidisciplinary discussions. The lowest effective dose should be administered and the overall propofol exposure should be minimized. A stepwise approach should be taken to increase propofol until appropriate sedation is achieved with subsequent decrease of other sedation and analgesic medications. While a specific plan really needs to be developed for each patient, a reasonable starting dose of propofol is 25 mics per kilo per minute, and it can be titrated every hour to effect. Paralytics, if they're being administered, should be discontinued first. If the patient remains sedated after that, the benzodiazepines and opioids can be weaned every 1 to 2 hours. I typically start with weaning the benzos, usually by 25% of the original dose, and once they're discontinued or reduced to the intended dose, I wean the opioids by anywhere from 5 to 20% of the original dose every 1 to 2 hours that's tolerated. If the patient is agitated during this process, the propofol can be increased, but in increments of 25 mics per kilo per minute every hour. In addition to monitoring for pain, agitation, withdrawal, and delirium during this process, patients should be monitored for propofol infusion syndrome, which can be fatal. Another symptom, delirium, is a relatively new concept in neonatology. It's most often discussed in older, medically complex neonates. Delirium is an acute neurobehavioral syndrome of cerebral dysfunction characterized by serious disturbances in attention, awareness, and cognition. This schematic shows that there's significant overlap with other symptoms. Manifestations can include altered consciousness and awareness, inability to maintain attention, changed sleep-wake cycles, and disturbed concentration. While diagnostic criteria exist, there really is a lack of experience in evaluating behavior and cognition in neonates, and it's often unrecognized, and some believe that neonates, especially in the first month of life, cannot experience delirium. The etiology of delirium is really multifactorial. If you look at the predisposing, precipitating, and perpetuating factors listed on this slide, our patients have multiple risk factors. Delirium can be exacerbated by iatrogenic factors such as polypharmacy or disease processes that lead to circulating cytokines, chemokines, abnormal neurotransmitter release, and impaired oxidative metabolism. Systemic inflammation can compromise the integrity of the blood-brain barrier or lead to a production of inflammatory markers and cytokine release in the brain. Additionally, hypoxia can reduce acetylcholine production and disrupt cholinergic, dopaminergic, and GABA regulation. That downstream dysregulation of melatonin, glutamate, serotonin, norepi, and histamine release further potentiates inflammatory responses. In theory, over time, this can lead to progressive neurodegeneration. Assessing for delirium is important, especially in our older complex patients. The CAPD score is a validated tool in neonates. Delirium prevention, I cannot stress this enough, delirium prevention should be the focus. Additionally, treating the underlying cause, delirium hygiene, and environmental interventions are paramount. This includes treating infections or medication withdrawal, decreasing certain pharmacological therapies when feasible, the benzos, opioids, anticholinergics, steroids, other dissociative agents, regulating sleep and day-night cycles, providing developmentally appropriate orientation, mobilization, and really involving families and cares. This should be the focus. When we think about pharmacologic therapies, melatonin, which controls the circadian rhythm, is dysregulated in patients with delirium. Exogenous melatonin has been used to treat delirium in other populations, and there's very little in the literature regarding neonates. Others have reported using gabapentin for delirium. If there's truly severe refractory delirium, despite all of the prevention strategies and maximizing all non-pharmacologic interventions, there very rarely may be a role for atypical antipsychotics, quetiapine, olanzapine. If there are no contraindications, quetiapine can be considered. It's important to remember that we don't know the long-term impact of using these medications in neonates. So in general, the smallest starting dose should be given and titrated to effect. And then within 24 hours of symptom resolution, it should be weaned off or for the course of several days. During this time, the patient should be continuously monitored and medication should be discontinued if arrhythmias or severe extrapyramidal side effects are noted. The remainder of the symptoms are really geared more towards end-of-life symptom management. One of the most common, visible, and concerning symptoms for families is respiratory distress. If a baby has hypotonia, impaired swallowing, or is intubated, they may have symptoms of respiratory distress during the dying process. Tachypnea, retractions, nasal flaring, and grunting are all very visible signs. Dyspnea is the subjective experience of discomfort with breathing. Most verbal patients report dyspnea at the end of life. So while there are no formal assessment tools for neonates because older patients report dyspnea, I think it's reasonable to associate the physical signs of respiratory distress in neonates with the subjective experience of dyspnea. It's important to prepare the family and explain what they might see and how we can make their baby more comfortable. Even if a patient is comfortable with appropriate symptom management, they may have physical changes in their breathing patterns. Position the baby so that their head is elevated or they're prone may open their airway and really relieve some symptoms. Use of a fan with air movement towards the face may relieve dyspnea. Skin to skin can be very effective at improving labored breathing. Gentle suctioning and fluid restriction when appropriate may be helpful. Additionally, the hypoxia and hypercapnia that occur during the dying process have natural sedative effects, which can decrease work of breathing. It's important to also consider how the redirection will occur. If a family is worried about gasping that will persist irrespective of treatment, would this be a time to consider a terminal wean on a ventilator as opposed to a compassionate extubation? When it comes to the pharmacological therapies, similar to with pain, even in the context of end-of-life care, can we treat the cause to alleviate some of the symptom burden? For example, if a baby has congestive heart failure, is there ever a role for diuretics in those final days of life? Irrespective of if there are disease-modifying therapies that can help alleviate respiratory distress, the symptom itself should be treated. Opioids, the first medications on this table, are really first line in treating respiratory distress or dyspnea. They reduce sensitivity to hypoxia and hypercapnia centrally. I like to describe it as numbing the lining of the lungs so that they can't sense that it's getting harder to breathe. Some believe that opioids are effective at lower doses than used to treat pain, but I typically start with similar doses, which is reflected on this table. In the NICU, the medications will most often be given intravenous, but there are times when other routes, mucosal or nasal, can be considered. And then at the bottom of the table, benzodiazepines, while helpful, are second line and only used in conjunction with opioids. I say that because they work through their anxiolytic properties rather than through directly targeting the symptom. This schematic shows a management approach for respiratory distress. Non-pharmacologic and disease-modifying therapies, when appropriate, should be started early, maximized, and continued if helpful. If symptoms persist, a starting dose of 0.15 mg per kilo morphine or 0.05 mg per kilo IV would be a reasonable starting place. The dose can be increased by 20 to 50% every 20 minutes as needed. Once opioids are maximized, benzos can be added. Rarely, if the patient isn't already on one, a continuous opioid infusion or dexmedetomidine infusion will be needed. Another symptom pretty closely related to respiratory distress is excessive secretions. Not all patients will have excessive secretions. They're typically seen in patients who are unable to effectively swallow and are the result of the inability to handle secretions as opposed to an increase in secretion production. This can be the result of the underlying disease process or from the decreased tone, alertness, and activity during the dying process. The secretions can also lead to gurgling or other sounds referred to as a death rattle. The symptom itself typically isn't uncomfortable, but can be very distressing to families. If the patient appears at all uncomfortable, it's appropriate to treat that symptom. Many of the non-pharmacologic interventions for respiratory symptoms are also effective for secretion management and noisy breathing. Gentle suctioning and repositioning, for example, are usually more effective than pharmacologic therapy. This has to be taken with a bit of a grain of salt because aggressive suctioning can lead to trauma, irritation, and increased secretion production. If the patient's on IV fluids, decreasing or discontinuing them can lead to less secretion production. And then for secretion management, repositioning the patient doesn't actually decrease the amount of secretion, but it changes the way they drain, making it easier for the patient to handle them. There isn't great evidence for the efficacy of pharmacologic interventions. With that said, anticholinergics, which are listed on this table, may be beneficial as they block acetylcholine either centrally or peripherally. If they act centrally, they can cause fever, tachycardia, constipation, and other physiologic symptoms. In proper doses, these side effects can really be minimized, and the effect of anhidrosis can help reduce or thicken secretions. There's little evidence, though, that they help with the actual death rattle. I would recommend starting atropine or glycopyrrolate, both of which can be given enteral or intravenous. I rarely use scopolamine, which is at the bottom of the table, because it acts centrally, so there are more of those systemic side effects. After repositioning and education, if secretions are concerning, atropine 0.02 mg per kilo can be given PO or IV for immediate effect, or glycopyrrolate 0.02 mg per kilo can be given IV for more long-term benefit. Both can be dosed every couple of hours. At times, glycopyrrolate can thicken secretions to the point where they can't be mobilized, making them more difficult for the patient to manage, so it really is a fine balance. The previous symptoms that I mentioned are by far the most common and distressing for families. There are a few additional symptoms that are worth mentioning, especially if you expect the dying process to take days, weeks, or more. For many, food has significant meaning beyond nutrition. If a baby is unlikely to die within minutes to hours, families may worry that their baby is hungry. Breast or bottle feeding can be offered for comfort, but should not be forced. It's really important in these situations to explain to families that as their baby is dying, their organs are not functioning properly, they will not feel hunger, and digesting food can actually be difficult. If a patient is receiving artificial nutrition or hydration, it may be appropriate to decrease or discontinue them because they may no longer be of benefit and can lead to fluid overload, edema, abdominal distension, or nausea. In our population, it's rare that constipation causes significant issues during the dying process, but if patients are on high-dose opioids or anticholinergics, they may experience some constipation. It really should only be treated, though, if it appears to be causing discomfort to the patient. Other symptoms are skin breakdown, dry eyes, dry mouth. You can easily involve parents in recognizing and treating these. Wounds can be painful, and it's much easier to prevent skin breakdown or treat it early. Many products, including medical-grade honey and various barriers, can be helpful. Additionally, reposition the baby, especially by encouraging parents to hold them, can decrease pressure wounds and edema. For dry eyes, artificial tears can be helpful. For the dry mouth, families can swab the tongue and the mouth with breast milk or water. For lips, petroleum jelly is helpful, and sometimes families like to use flavored lip balm so their baby can taste flavors they otherwise would never have an opportunity to. While these symptoms aren't incredibly distressing to patients in general, they're very visible and something families can actively treat, and by doing so feel empowered as parents. It is incredibly rare that end-of-life symptoms cannot be managed with an escalation of traditional pharmacologic therapies, but in cases of truly refractory symptoms, it might be reasonable to consider palliative sedation. The goal of palliative sedation is to provide effective symptom control through decreasing the level of consciousness without hastening death. It really occurs across a continuum from anxiolysis to deep sedation with loss of consciousness, and is classified as either proportionate palliative sedation or palliative sedation to unconsciousness. Proportionate palliative sedation directly targets the symptom with the medications, while accepting at higher doses sedation is a side effect. Palliative sedation to unconsciousness, on the other hand, is provided using classes of sedative and hypnotic medications that alter the level of consciousness but do not directly treat the symptom, in conjunction with medications that target the symptom. Agents commonly used include propofol, phenobarbital at high doses, ketamine at high doses, or dexmedetomidine at very high doses. Palliative sedation has really been supported by the AMA, National Hospice and Palliative Care Organization, AHPM, and AAP. While I think it's rarely utilized in the NICU, it may have a role for patients who have truly refractory symptoms and a lengthy history of exposure to the pharmacologic therapies typically used to treat these symptoms. Now that I've given a very quick overview on symptom management, I'll use the information to walk through a couple of clinical cases. The first is a 5-week-old male, late in pregnancy, a Dandy Walker malformation and polyhydramnios were noted. The family was given a wide range of prognoses and told that he may not be able to effectively swallow or breathe. After delivery, he was also noted to have a cleft palate, coloboma, some other physical features. He had significant respiratory distress and really multi-level airway collapse requiring non-invasive respiratory support or prone positioning. He has no gag reflex and there's concern for aspiration with feeds. He has increased irritability and in the first weeks of life has started on scheduled gabapentin, 5 mg per kilo Q8 and lorazepam 0.05 mg per kilo Q6 PRN. At about a month of life, genetic testing results consistent with Charge syndrome. The family is told at this point that he will have profound neurodevelopmental impairments, will be legally blind, cannot hear, and given his multi-level airway collapse and inability to handle secretions, would likely need a tracheostomy. They've really started to begin navigating their goals of care when he has an acute decompensation requiring emergent intubation. Several days later, after many discussions, the family expressed that they believe that their son is suffering and will never have a good quality of life. They hope to spend some time with him and then let him die peacefully. When I think about potential symptoms, I wonder how long he'll live for. Prior to the acute decompensation, he had been on non-invasive respiratory support for several weeks, so he might live for several hours or maybe even several days. Given his absent gag and neurologic status, I worry about his ability to handle secretions. With the multi-level malacia, he'll likely have gasping and very visible signs of respiratory distress. Since he has agitation at baseline, this will likely continue and his neuroirritability may get worse. I think it's also important to remember that this is all in the context of a baby who cannot see or hear. This will be a planned redirection of care, so we have time to plan and also prepare the family. I discussed timing in terms of minutes to hours, hours to days, days to weeks or more. The family should prepare that he may live for hours or potentially even a day or so. If they aren't, they may worry afterwards that the prognosis was different than we're told. When discussing secretions and gasping, I describe it as similar to snoring so that the family understands that while what they're seeing is uncomfortable to watch, it's not uncomfortable for him. Similarly, with respiratory distress, it's very difficult to completely take away the physical signs, but we can give medications to make him more comfortable so that he doesn't sense that it's getting harder to breathe. And then when he is close to dying, they'll notice that he's not as alert, his color is changing, and he feels cool to touch. He'll start to have pauses in his breathing. In addition to explaining what we expect, we can explain what we plan to do and what they can do. He has a peripheral IV and an NJ tube for medications. Since we're worried about his ability to handle secretions, in addition to preparing the family and teaching them ways to position him, we can preemptively start scheduled glycopyrrolate 0.02 mg per kilo Q4 IV. If he didn't have the IV, you could give it through that NJ. At the time of extubation, we can also make some PRN atropine 0.02 mg per kilo IV available. We expect him to have pretty significant respiratory distress. For some families, the thought of that might be so distressing that they might prefer a terminal wean on the ventilator. But in this case, as long as we think he's comfortable, they're okay with his breathing, look, and labor because they really want to see his face without that endotracheal tube. Since he hasn't had much opioid exposure, it would be reasonable to start intermittent morphine 0.05 mg per kilo IV as it's a little longer acting than fentanyl. We could give the first dose 15 to 20 minutes prior to extubation and titrate it every 20 minutes to effect. I wouldn't expect him to have too much pain, but would expect his agitation and neuroirritability to be significant. We can preemptively increase his gabapentin to 15 mg per kilo through that NJ. We can also add a dexmedetomidine infusion at 0.5 mg per kilo per hour or scheduled lorazepam 0.05 mg per kilo Q6 IV. It's important to remember that he can't see or hear. So in addition to that low stimulation environment, we can teach the family how to prepare him to be held or touched, such as gentle vibration or graded touching, so that he'll be prepared and it'll be soothing, hopefully as opposed to a surprising experience. Even though he can't see or hear, he can feel the vibrations of his family. With these measures, after extubation, he's initially agitated, but this improves once the dexmedetomidine drip is increased to 1 mic per kilo per hour. His morphine is essentially given Q4 hours for respiratory distress, and he ultimately dies peacefully in his mother's arms 12 hours after extubation. Our second case is a former 35-weeker with congenital diaphragmatic hernia, giant omphalocele, Beckwith-Wiedemann syndrome. There were extensive prenatal conversations about the prognosis. After delivery, he was placed on ECMO and ultimately decannulated at about 2.5 months in the setting of severe IVH. I won't go into all of the details of his medical course, but for these purposes, it's important to know that he has severe pulmonary hypoplasia and pulmonary hypertension, for which he's on multiple medications. He's intubated his entire life and ultimately has a tracheostomy placed. He's had multiple surgeries for his diaphragmatic hernia, omphalocele, and subsequent wounds. Throughout the NICU stay, he's had feeding intolerance, multiple infections, and at times multi-organ failure. So he's been critically ill most of his life. He's been in the NICU for over a year, and during that time has had significant issues with pain, agitation, and neuroirritability. He was on high-dose opioid infusions with rotation of opioids, methadone, a midazolam infusion, and dexmedetomidine most of that NICU stay. At one point, he required a propofol washout. He was also started on gabapentin for neuroirritability and quetiapine for delirium. At approximately 12 months of life, he was weaned off the infusions and discharged home on scheduled methadone, gabapentin, and clonidine. Unfortunately, he returns to the hospital about 2 weeks later and is admitted back to the NICU with acute respiratory failure secondary to pneumonia, and ultimately developed some sepsis. During this hospitalization, his ventilator support is rapidly increased and his pulmonary hypertensive medications are maximized. He shows significant signs of pain, agitation, and irritability, and his analgesia and anxiolytic medications are rapidly escalated. His methadone is continued at 0.05 mg per kilo, but transitioned to IV, so likely a fair increase in the dose. His home doses of gabapentin and quetiapine are continued. In the previous month, he had been on morphine and fentanyl infusion, so this time when he was admitted, he was started on a hydromorphone infusion that was increased over the course of a week to 0.08 mg per kilo per hour. His home clonidine was transitioned to a continuous dexmedetomidine infusion that's ultimately increased to 1 mic per kilo per hour. And after that, because he's still agitated, a midazolam infusion is started and increased to 0.08 mg per kilo per hour. With this regimen, he's awake with intermittent periods of agitation. Given his critical status, there's multiple conversations with the family, and after they spend some time with him, they want us to remove the tracheostomy and let him die peacefully. Given his complex medical course and current level of support, I anticipate that he will likely live for hours at most. I expect him to have pain, agitation, and respiratory distress. Knowing his baseline symptom management needs, how should we approach managing his symptoms? 48 hours prior to decannulation, we can increase his methadone by 25% to 0.06 mg per kilo Q6, his gabapentin by 50% to 15 mg per kilo Q8, and his quetiapine by 25% to 2.5 mg per kilo Q12. With this, he continues to show signs of agitation. We continue his midazolam and we increase his dexmedetomidine by 50% to 1.5 mics per kilo per hour. Several hours prior to redirection, for signs of pain and anticipated respiratory distress, we can increase his hydromorphone infusion by 100% to 0.16 milligrams per kilo per hour. With this, he really remains alert and awake. PRN hydromorphone at 0.16 mg per kilo and ketamine 1 mg per kilo are available. 15 minutes prior to his redirection, we can give him a PRN dose of the hydromorphone and then the ketamine. With this, after his tracheostomy is removed, he lives for a total of 6 hours and requires 2 additional doses of hydromorphone and 1 dose of ketamine without the need for palliative sedation to unconsciousness, and ultimately has a peaceful death surrounded by his family. I hope those cases highlighted how nuanced symptom management can be. While I've made medication and dosing recommendations, I think it's important to remember there's very little research on symptom assessment, symptom management, and interventions used in both our complex NICU patients and neonatal end-of-life care. This really makes it difficult to come to a consensus about standardized approaches. Although the ultimate symptom management plan really needs to be tailored to each patient, it's important and helpful to have guides in place to improve consistency in management. This slide has a table with a summary of the medications I've mentioned with doses I typically use. The route can be determined by the access the patient has and goals or location of care. Continuous infusions are typically only used if the patient is already on them or requires a rapid escalation of management. This is really for your reference, so I won't mention all of the medications, but I can review the ones most frequently used. For severe pain and respiratory distress, opioids are first line. Morphine is most commonly used with typical enteral doses ranging from 0.15 to 0.5 mg per kilo, IV doses ranging from 0.05 to 0.2 mg per kilo, and continuous infusions ranging from 0.01 to 0.05 mg per kilo per hour. If the patient is already on morphine, depending on the severity of symptoms, a 20 to 100% increase in dose may be required. The opioids can be titrated until there's a lack of clinical benefit or their side effects. This is when you can consider that opioid rotation. Just make sure you know those equal analgesic doses when converting. Another common medication, dexmedetomidine, is useful for pain and agitation. It's most commonly given as a continuous infusion at 0.5 to 1 mic per kilo per hour. You can at times, though, escalate a little higher to 1.5 or 2 mics per kilo per hour. And then when benzodiazepines are used for agitation, lorazepam is longer acting than midazolam, but midazolam is a nice option for a continuous infusion. Lorazepam is typically dosed 0.05 to 0.1 mg per kilo enteral or IV, and midazolam is typically dosed 0.05 to 0.1 mg per kilo IV. Remember, with the benzos, there can be a paradoxical reaction at higher doses. This is a schematic. It might be a little hard to see depending on the size of your monitors, from a paper related to end-of-life symptom management, similar to what I showed for individual symptoms throughout the talk. Optimize non-pharmacologic interventions early, as they can be very effective. When pharmacologic treatment is necessary, medication choices and doses may need to be adjusted based on prior exposure. Medications should be introduced really and titrated in a stepwise approach. At times, higher doses are needed to achieve adequate symptom management, or alternate medications need to be utilized. In rare circumstances, palliative sedation may be appropriate. In any of these situations, if you're not familiar with alternatives such as ketamine, dexmedetomidine, or gabapentin, discuss the plan with individuals who have expertise ahead of time. And I know we're running short on time, but in conclusion, appropriate symptom management, while challenging, is important for neonates in the NICU. It improves comfort for the neonate, minimizes long-term effects, and impacts the family's experiences. While there are challenges with identifying and quantifying symptoms that neonates experience, providers and families commonly report respiratory distress, pain, and agitation. Interventions such as decrease in painful stimulation, procedures, ensuring normothermia, and repositioning can be very effective. Oftentimes, though, the non-pharmacologic interventions are inadequate. It's really important to identify if there's a treatable cause of the symptom in developing an effective treatment plan. For example, dyspnea that's secondary to pneumonia may be treated differently than dyspnea secondary to congestive heart failure. Beyond that, pharmacologic therapies targeting the symptoms can be effective if providers really understand the etiology of the symptoms and how the medications work. It's also really important that the healthcare team clearly communicates with the family. By setting expectations and helping them understand the changes they will see, they can better prepare themselves and begin to understand the difference between physiologic changes and signs of distress or discomfort. And with that, I am happy to take any questions. I will also advance to the final slide for the CME information.
Thank you so much, Dr. Cortezzo, for such a wealth of information. We do have questions in the chat that I will launch into, but of course, everyone who's registered, please take a look at the QR codes as we are going through the questions. So our first question is, once you start gabapentin, how do you decide what dose to increase to, and when do you try to wean off?
Yeah, that is something I feel like we're still trying to standardized approaches for in neonates. Even starting doses are different. Some people will start anywhere from 3 to 5 mg per kilo. Some start at once a day to 3 times a day. I will generally start at around 5 mg per kilo 3 times a day and go up in increments of about 5 per kilo per dose and titrate to effect. I will wait till a patient is free of symptoms of neuroirritability, and it really depends on the situation. If it's a child that I expect to have continued neuroirritability, I will continue that, and it's almost a maintenance medication. But if it's situational, for example, visceral hyperalgesia or related to neuropathic pain from an ischemic limb over time as those symptoms have resolved, then I will wean typically by 20% of the original dose every 24 to 48 hours down to the starting of either 3 to 5 mics per kilo 3 times a day, and then space that out every 24 to 48 hours until it's off.
Thank you very much. We also have a question kind of targeting the chronic neonatal population, corrected gestational age greater than 6 months, that this group can be very hard to manage. This attendee says our unit still uses Valium. Any role for this medication in the older population?
I think anytime there's a spastic nature to what you're seeing, increased hypertonicity, Valium may be very effective. But you're right, I would typically only use it in the older 6 months and above population.
Okay, and we have a question also about the rotating of the opioid. So when you rotate your opioid, do you ever use a different percentage dose reduction depending on clinical circumstance?
I do. I typically, if symptoms are fairly well controlled because of that incomplete cross tolerance, I will do a 20% dose reduction. Sometimes if the patient is very comfortable, closer to 50%.
Okay.
And then if the symptoms aren't well controlled, I may just keep it at the equal analgesic dosing.
I actually had a question myself about the propofol washout, which is fascinating to me. I'd never encountered that before. Is the goal for the washout to be off of all of the other medications?
The majority of the times it is. Sometimes you will have them at a lower dose, but if you can completely take them off of the medications, that rapid decrease will cause those receptors to have increased sensitivity, so that if you need to start them once the propofol has stopped, you can ideally then start at either a typical starting dose or a much lower. So for example, if you had a patient who was on, or like our last patient, the 0.16 mg per kilo per hour of hydromorphone, if you were rapidly weaned it off during that propofol infusion, you might be able to start it at 0.04 mg per kilo per hour.
Okay, so sometimes the goal is off and sometimes it's just less.
Yeah.
Got it.
And it goes back to the clinical situation, and if you believe that the child is still experiencing significant pain or agitation.
Do you find at your institution that that's usually neonatologists able to do that, or is it anesthesia, palliative care? Who handles that kind of drug?
Yeah, it is very different, and every hospital has different rules and regulations, and some only anesthesia can administer it. Most places, intensivists can. I know some centers where it's the PICU because a lot of the neonatologists haven't been trained to do it. Certainly, I've used the medication in the NICU before, but it really requires everyone, all of your colleagues, to know how to titrate the medication. It requires education of the multidisciplinary team, including nursing, to really understand signs, symptoms of propofol infusion syndrome that you have to keep a close eye on, and how to monitor for other side effects.
Some of our questions in from the email, actually, you covered many of them, like the role of gabapentin, helping a baby with poor state control. One question was about kind of end-of-life medications. Do you have sort of a you did speak about this a lot, but do you have kind of a typical approach that you start with, or is it really a la carte?
It depends on the clinical situation. For example, if there's a neonate who has multiple congenital anomalies and the plan is from the delivery room a comfort measures only approach to care, treating the respiratory distress in that situation, I would typically give enteral morphine 0.15 mg per kilo as needed and titrate it to effect. If we're in the situation where it is a 3-month-old who's been in our NICU and on infusions, then I would approach that a little bit differently.
Well, thank you very much, Dr. Cortezzo, for your time and this wonderful webinar. I think we all gained quite a lot of knowledge from it. And I'll just point our registrants back towards the MOC and CME credit, and also our upcoming webinar in a month.
Well,
Thank you very much, everyone.